Good evening, everyone. Thank you for joining us tonight. My name is Dr. Maulik Shah. I am the Executive Director of the HonorHealth Cardiovascular Center of Excellence and Cardiovascular Services at HonorHealth. I'm a practicing cardiologist and excited about the opportunity to talk to you with one of my close friends and colleagues tonight about the importance of cardiovascular prevention. As everybody probably recognizes, February is our Heart Awareness Month, where we focus on heart disease. Unfortunately, 1 in 4 of us will die from cardiovascular disease, and it's the #1 killer of all Americans, both men and women in the United States, and unfortunately leads to more deaths, heart disease does, compared to all forms of cancer combined. So it's a big deal. And the reality is that more than half of these deaths could be prevented by understanding what we can do to prevent heart disease. And tonight we have the luxury and opportunity to speak with a national expert in cardiovascular prevention, my colleague, Dr. Wes Tyree. Dr. Tyree is the HonorHealth Director for Cardiac Rehabilitation Services and oversees the rehab process for many patients across the metropolitan Phoenix area after they've had heart stenting and heart valve surgery. And his passion is really focused on how to prevent heart disease in the first place so that people don't need these exotic procedures that they sometimes do get. So Dr. Tyree, thank you for joining us tonight.
Thanks, Maulik, very much for having me. Pleasure to be here.
Absolutely. Dr. Tyree and I actually practice together in the same hospital and same clinic, and so we've had a chance to talk about the care of patients over the course of many, many years together, and he's a great resource for me as I oftentimes have difficulties or challenges with particular patients. So I'm really excited to share with everyone Dr. Tyree's knowledge tonight. Wes, thanks for taking the time to join us.
No, thanks, Maulik. I really appreciate it. I know bantering stuff off of you over the last 7 years sitting next to you has been great, and we've learned a lot from each other, I think. I've learned a lot from you, too, so I really appreciate the opportunity. Yeah, thanks for having me.
Absolutely. So, Dr. Tyree, let's start at the very beginning. What are the big risk factors that you think about for a patient as you think about, hey, will this patient develop heart disease, and will it be a big deal for that patient's life?
Yeah, absolutely. I mean, risk factors, I think everybody going to their primary care physician gets kind of known about their risk factors. What are the obvious things? High blood pressure, high cholesterol. Are you a smoker? Do you have a family history? Are you diabetic? And there's a lot of those things that we address during those talks. And there's ways now that we've kind of got a little more sophisticated. We used to have the Framingham trial, which was back in the day. All the great early data came for prevention from the Framingham studies. And now we have pooled cohort equations that we use now in the clinics that are really helpful. And I don't know if you use them. Do you use the app, the ASCC app?
I do sometimes, but yeah, you should point it out to everyone.
It's actually a very handy tool that we use in the clinic, because what you want to do, you want to calculate a 10-year risk for people. You'd also like to calculate a lifetime risk for people, especially people that are 40 to 79. The 10-year risk is quite important. Some of the data from the pooled cohort equations don't really hold up for younger and older patients, but within that middle ground, we can kind of garner what kind of risk you have over the next 10 years. And between, if it's less than 5%, which puts you to lower risk, or if it's over 20%, which is super high risk, we kind of have a good idea with those people. You're going to be really aggressive with those people.
So you're trying to get a sense of their overall risk, and the calculator helps you. So walk us through some of the basic things, because everyone hears about them, and they always hear about the concept of taking the time to know your numbers and taking the time to know your risk factors. But starting with cholesterol, what do you look at in cholesterol, and why is it important in the first place?
Yeah, I mean, cholesterol is obviously, we look at LDL numbers, and we were all taught that initially, right? The lower the LDL is, the better off, and the lower events. And there's curves that we've seen in lots of talks where that's a linear slope, and it never really stops. The lower you can drive the LDL, you're better off. Some people, though, don't need quite that reduction. And so the middle ground people in that 20% to 5% range, where you're kind of cultivating what do you really need to do for them. There's some other tests you can do. You can do calcium scores, and you can look at other risks do they have on top of the major risk factors.
And one of the things that you taught me, and so for those of you who don't know, Dr. Tyree has actually studied lipidology, which is the study of cholesterol. And so when he's talking about LDL cholesterol, L standing for low density or lousy, as a way we like to explain it to patients, in that the more bad cholesterol you have or lousy cholesterol, the more your risk is overall. And then I think HDL, or healthy cholesterol, which is the high density lipoprotein that we like to have overall.
Right.
When you look at those numbers, how do you look at it? Just like, what are good numbers, what are bad numbers?
So LDLs, if you looked at LDLs over 160, whereas those are the people with their very high risk, and those are the people you want to be aggressive with, absolute numbers. But the risk within that kind of pretends how much do you want to lower it. People at high risk, you'd like to lower that 50% by the new guidelines, so you bring your LDL down by half. People with moderate risk, you'd like to bring that down about 30% with medications or otherwise. So you look at the LDL, then you look at the triglycerides, which is kind of the second one, and triglycerides are a little bit different. No, direct triglyceride elevation is not incidentally tied to coronary disease, but the combination of triglycerides with obesity and elevated blood pressure and elevated sugars portend the metabolic syndrome, which is a different animal that we look at, and those people can definitely be higher risk for sure.
And so the way I've always been taught is that for every 10 points your HDL is higher compared to baseline of, let's say, 40 or 50,
right,
your lifetime risk for having a heart attack or a stroke goes down by nearly 20%. So all those little numbers actually do add up with time. And so let's say, Dr. Tyree, when you have somebody that has high LDL cholesterol or high triglycerides, what do you do? And I see you put up the scale here. So tell me what do you look at first?
For high HDL?
Yeah, high LDL.
High LDL.
Yeah.
I think you got to look at the other extra risk factors. Is there a family history of heart disease? And I think that's one of the biggest ones that's underestimated. Do they have that? Do they have, if they're a woman, do they have any issues with early menopause or preeclampsia, other sorts of risk factors? Do they have chronic renal insufficiency? Do they have inflammatory disease? There's other things outside of the traditional risk factors.
So you look at the big picture, whether they've got family history, kidney problems, what their sedentary lifestyle, things like that.
Are they exercising? For sure, and weight is a big one, absolutely. Because weight affects really every risk factor, right? If you're obese, you're higher risk for diabetes, have higher blood pressure, those sorts of things. And so when you have that sort of patient, if you can get in and help with something that's going to modify all those risk factors and bring them down to a better level, which could simply be just a good dietary pattern to get that going, that's a great place to start, I think.
And so does diet and exercise really improve your cholesterol number?
Yes.
Okay.
Yeah, absolutely. But you need to look, so dietary number is what I usually tell people in some of the smaller studies. To burn for aerobically 2,000 calories a week is what you'd like to see. And that's 4 or 5 good aerobic sessions, if you can. 2,200 calories has been shown in a couple small studies to actually reduce plaque size to some level, but those are really small things that have to be vetted out a little bit better.
And I've seen with exercise and diet that some of my patients have a cholesterol level that drops by nearly 30 to 50% if they really push it. Is that what you've seen as well?
Absolutely.
So you're not destined for your fate if you actually take intervention and actually do the things that you need to do.
No, not at all. And it affects triglycerides probably more so than LDL. Triglycerides, and that's why I kind of leave some people, if their triglycerides are a tad bit high after surgery for secondary prevention or bypass or a stent, I'll kind of leave them that 20 points of 170 of a triglyceride to put that in their lap and say, hey, you've had these things, can you work with diet and exercise to move that number? And usually they can. You have a lot of motivation after those sorts of procedures to help that.
So you've spoken about cholesterol so far, and one of the things is diet. With cholesterol. What about medications? Do those work?
Oh, medications, yeah. I mean, statins are kind of the cornerstone of the drugs that we use for LDL cholesterol. And
we've already got a couple of questions that people have called in about statins, but we'll get to that later on. But
okay.
Go ahead.
No.
Right, so statins work?
Statins work, absolutely. For people who can't take statins, Zetia is one of the options that we have to add on. Also for LDL, now we have the PCSK9 inhibitors, which is the injectable
What are
drug.
those? So tell us a little bit more about that.
PCSK9 inhibitors are a newer drug that can lower LDL cholesterol. That's an injectable drug that's twice a month. If people have failed statins, so say you have muscle aches, they just don't like them, and people have a really kind of bad feeling towards statins in general. I know if you see that in your clinic or not, they get online, they look at all the stuff that
Yeah, unfortunately, statins are fantastic. The data on it for the last 35 years is really showing that people can have a reduction in their cardiovascular event rate, meaning they have lower heart attack rates, lower stroke rates, do much better overall. But I do have patients that sometimes cannot tolerate them because they have muscle aches or liver problems from it or other things.
Right.
And so I have been excited about the advent of these PCSK9 inhibitors. Are they tough to take?
They're not tough to take, and actually the side effect profile on them is pretty good, and they work really well. I mean, you see people with very low LDL levels to the point where people have been studying these low LDL levels to make sure we're not hurting people with LDLs below 10 in certain cases. And so far, the data's held up well. People do well with these drugs. They do really well with them. If you can't get somebody below 70 even with a statin, it's actually indicated too to even move it lower than that if you've added on everything that you can add on.
But I think one of the coolest things about what you're mentioning is that for those people that can't tolerate statins or don't want to take it, now there are options that have actually been proven to reduce your cholesterol and your risk for having heart attacks and strokes. So that's been great.
Yeah, it reduces events. I mean, that's big. You know, they aren't cheap, I guess to say, and sometimes you have to have failed all these drugs to you know, to be on a PCSK9 inhibitor for the insurance to pay for it. Otherwise, it's a little out of pocket, but sometimes your health is worth it.
And this picture here, so we've spoken about medications.
Yes.
Tell me about, what do you think about this diet here? I know we're going to get to it a little bit
later on. That's a great plate of food right there if you're a cardiologist looking at your patient's dinner. So for sure. I mean, Mediterranean diet is the heart diet, you know, absolutely. And the thing about the Mediterranean diet too, it doesn't really lower your LDL a ton. It's more probably an anti-inflammatory effect, and also, you know, lowers triglycerides a little bit more. But if you look at the Lions study, people would have 35% less chance of having events after bypass just by this diet alone. I mean, there's few medications that do that.
And I want to make sure we go over all the main risk factors.
Yeah.
So we spoke about high cholesterol.
Right.
High blood pressure, is that something you look at as well?
Oh yeah, blood pressure for sure. Hypertension is underestimated as a risk factor. And control of blood pressure today is probably, that's one of the things the AHA is looking at to move forward with absolute control, better control of blood pressure to lower events across the board.
Yeah, I mean, the unfortunate reality from what I read is that almost a majority of Americans have high blood pressure at a time, and then it's very difficult to control, but if you can control it, your risk for cardiovascular disease goes down a lot. For every 20 points, your top number or systolic pressure is above 120, your lifetime risk for a stroke or heart attack, I think, is up 33%. Or lifetime risk for dying is up 20%. So those small numbers of that constant wear and tear of that high blood pressure against your brain and heart can cause trouble, but there are therapies. And so it's so good to really focus and know your numbers on the high blood pressure part.
Right.
So high cholesterol, high blood pressure, what else do you look at? Weight?
Yeah, weight is important. I think distribution of weight becomes more important than BMIs just as a whole. Some people are more muscular. Some people put fat in different places. You know, some people have more belly fat than just regular, you know, this subcutaneous fat all over. So distribution of that is important, but keeping an healthy weight is crucial.
And smoking history, obviously, as well?
Smoking, don't smoke. I mean, diabetes and smoking are 1 and 1A as far as heart risk factors go. Those are the two on the top, you know, and smoking is easily controlled. That's probably the biggest one if you look at it.
Unfortunately, I think 1/5 of the country still smokes at times. So I think it's really important that you point that out.
Yeah.
There's nothing good about it. It does increase your risk for heart disease. It does increase your risk for cancer. So it's a big deal.
There's studies that show that if you quit smoking versus quitting all your medications, you're better off staying off cigarettes and not taking drugs for a longevity purposes. So it's that big of a deal.
So just important to highlight that you need to know your risk factors. You need to know what they are, and you try to modify them or improve them as much as possible. But one risk factor that you can't necessarily modify that I want to focus on now is your parents or your genes, who you are. So tell me about family history of heart disease. Is that a big deal?
Family history is a big deal, and people with family history, if your dad's before 55, your mom before 65, if they had early events, heart attacks, strokes, possibly even, I mean, those are the people you worry about. Those are people that are ideal to attack early in the prevention process too. You know, there's a twofold increase of risk of events, you know, with a family history. So you got to be careful.
So let's say I'm 46 years old and I have a family history of heart disease, or I'm 36 years old, but I'm not feeling anything. Should I get screened? And I see you have up here, what is a coronary calcium score?
Yes.
So fill me in a little bit. What do you think you should do?
So for these people, what you do is you get your baseline cholesterol numbers, and what I do after that is I'll say the calcium score is maybe the best thing to get for people in the middle ground, the 5 to 20% range. The people with intermediate risk, this is the test you do, because if this test comes back 0, your risk of having an event over the next 5 years is
so walk us through what are they checking when they're checking the calcium score?
The calcium score looks basically directly at the arteries to your heart.
So it's a CT scan, it looks like?
CT scan, quick CT, there's no contrast, and it tells me, do you make plaque? And do you have the disease process? And based on that, how worried do I have to be about you, going forward? And so if your cholesterol is kind of borderline, and I love this test for people whose cholesterol, like LDL, is between 100 and 120, 130, this is kind of almost the deciding factor, because if this comes back 500 and now you're in the 90th percentile, for people your age, I mean, you're going on medicines, and we're going to be
So the
aggressive
good thing
with
about
this.
it, from what I've seen, is that for patients, it gives them a sense if they've started to accumulate any plaque, and then it compares you to other people your age. And so it gives you a sense truly compared to other people where you are with respect to your risk profile.
Exactly.
And then, like you're saying, it can guide therapy and tells you how aggressive you need to be with potential exercise, medication, things like that.
Absolutely. And if you're over the 75th percentile for your age, I mean, that's early disease. And so you got to kind of respect that, even if it's a trivial number. I mean, calcium scores even less than 10, but not 0, have still almost a double incidence rate of cardiovascular events. So it's not nothing when you see just a tiny little bit there, even though people don't necessarily be on drugs for that. And it's also knowing where they stand is also, there's a lot of data showing people are more motivated to do what they're supposed to do once they know. If you know you have disease, you're going to be out, you're going to be at the gym, you're going to be putting away the desserts, you're going to like all the good stuff. We may not put away the desserts, but
Super Bowl weekend, we got to be careful
exactly.
here with what we
Super Bowl in
commit
the
to.
open, okay, yeah.
So
we'll start this on Monday.
Yeah. So let's talk about what, just diet. What should people be eating? It's so hard because there's so much there's a lot of fad diets that are out there. Everyone's got different tastes that they like. So what do you recommend for your patients?
I mean, it's still Mediterranean diet, and basically a lot of the concepts around the diets that are kind of in vogue really involve getting red meat down to a couple times a month at most, getting rid of high-fat dairy products, okay, and getting rid of easy carbs. And easy carbs, what I mean by that is like cookies, cakes, pastas, baked goods, all the stuff that we like and all the stuff that's kind of sitting around. Your body just tears through those carbohydrates quickly, and then they go to triglycerides very early.
And if they are using cooking oils, using olive oil?
Olive oil is much better than even coconut oil or than the other oils, so for sure.
And the data seems to be quite strong. So this has been studied in several populations across the globe, and it seems to be that if people can abide by a Mediterranean diet, their risk for heart disease is much lower than those that can't.
It's like a 30 to 40% reduction.
Does it taste good? Do you like it?
Yeah, you can make a Mediterranean diet pretty well. I mean, chicken, fish, fruits, vegetables, whole grains, you can make a lot of stuff with that. And if you look at some like the keto diets or the very low carb diets too, those are high in animal fats, high fat dairy, different fats, and so those actually raise
those are
LDLs.
Not good. Yeah.
There's some
for
data
heart disease.
For heart disease. Yes. So but I mean, because you can take like the Ornish diet, for example, it's extraordinarily high carbohydrate, minimal fat, but also has tremendous reduction in cardiovascular risk. So diets are, the best diet is the one you can follow, right? The one that people will stay on. And so you got to kind of pick and choose your battle.
But I think that's a great point. The Mediterranean diet is a sustainable diet, which really people can abide by for years.
Oh, yeah.
And it really does reduce your risk for having heart disease and other things. So that's good.
Absolutely.
I was going to say that with respect to other risk things, so just what else do you look at in somebody's risk profile when they walk in? So you mentioned high blood pressure, high cholesterol, whether they're smoking, whether they're diabetic, what their weight is, what their family history is. Do you think about stress? I mean, it's been a weird 2 years that we've been going on in COVID. Do you think that stress plays a role in your risk for cardiovascular disease?
Yeah, I think stress plays a very big role in that. And everybody's stress level went from the pandemic, went from the floor to about the level of this chair. So now everybody's starting here. Stress plays havoc on blood pressure, too. Also raises like cortisol levels. Sometimes people don't exactly put fat in their belly when they weren't, doing that before. So there's a lot of different things that stress can be involved with. But raising blood pressures is probably one of the bigger ones. How many people do you see walking in like, oh my God, I just had this happen to be on the road, and their pressure's like 150 and 160, and
I think you're exactly right. I mean, the data that you pointed out, that it can raise blood pressure and raise your stress hormones or cortisol levels in your body is so true. And I see patients coming in like that who are high stress, who have a higher risk. There's an interesting study that came out in Europe once where they looked at a town that was in a soccer league, and it was their soccer league's like playoff system. And they looked at the heart attack rates during that period of time, and unfortunately, soon after games or a few days after the games, people's heart attack rate in that city was higher
when there was so much stress. So even in Super Bowl weekend, we got to be careful that we're just focused on the right things, the right diet, low stress overall. How about sleep? What do you recommend for your patients?
I mean, everybody, 6 to 8 hours is ideal. Who's getting that in a real world scenario? Probably closer to 6, maybe. But good sleep is important at any time, and knowing asking, the other thing about sleep is asking partners too, are you snoring? Are you stopping breathing? Those sorts of things, because sleep apnea plays a big role in, cardiovascular disease.
Absolutely. So sleep apnea and that snoring can raise your blood pressure, raise your risk for having abnormal heart
puts a lot of stress
rhythms
on the right side of the heart for sure. So so that's another thing too. You can get people with sleep studies to maybe help that as well. So sleep is, getting a good night's sleep is important.
So I think those are the things that are underestimated, trying to make sure that you have a low stress diet, life as much as possible, sleeping. How about other things, dentition? I think inflammation in your body seems to be a problem, is that right?
Inflammation, yeah. And so some people have looked at dental work, and if there's dental issues, cavity, they think the inflammation causes the beginnings of fatty streaks where cholesterol then implants in blood vessels. Maybe also bad teeth can lead to heart infections, which can be much, much worse than
But it does point out that everywhere in your body, you got to make sure you're taking care of the whole thing so that the inflammation and stress on your body is lower, which in turn decreases your risk for having heart disease and strokes.
Right, especially in the beginning.
And so one of the best ways to reduce your blood pressure, stress level, cholesterol seems to be exercise. But there's so many different ways to exercise. What is truly a heart-healthy exercise regimen?
A heart-healthy exercise regimen is one you can sustain. And that sounds dumb, and I'll give the exact numbers in a little bit, but I mean, if you're losing weight or if you're trying to maintain weight, either way, it doesn't matter. Just you have to find what you like and break a sweat.
Okay.
That's really kind of what it is.
But that's important. So I think that's important because I have a lot of patients that ask me about, hey, is weightlifting good? Or I work out at the gym and I lift, I do a lot of resistance training.
Right.
But I think for the heart, people oftentimes underestimate that it's the aerobic workout that you need to do where you're getting your heart rate up. That's the most important part. Right. Is that what you tell people?
There's moderate intensity exercise and then vigorous intensity, which is over 7 METs, where people are, you're really pushing it. For moderate intensity, the recommendation is about 300 minutes a week. Okay. Right? For vigorous, it's
300 minutes per week.
For moderate, and that's a walk. Something a little slower. Vigorous intensity is about 150. And for people actually who push it, the vigorous intensity people have less events over time. So the more you can push it, the better off you're going to be. And that kind of coincides with interval training.
How do you know you're pushing it?
I think that, you can look at the machines and tell you the METs, and kind of when you're getting tired a little bit.
Yeah, I tell people that at the end of it, if you're doing at least vigorous, you should have been breaking a sweat, at least a light sweat by the end of it. It's sort of a poor man's way of watching your heart rate. But at least, so the numbers that you're mentioning, 150 per week. So that means you probably need to be doing at least 15 to 30 minutes of aerobic exercise daily or 5 times per week. Is that what
most days a week for sure?
Yeah.
Most days a week is the best way to do it. But exercise in general, if you can find something to sustain it and create the habit, that's the biggest thing. Because people start and fail exercise programs constantly. They just don't get up, they quit going to the gym. Then COVID, gyms were closed, and you're stuck at home with all your food. And so a lot of people got in a lot of trouble during that whole period. But exercise and the sustainable portion is crucial. And that also, just like weight loss, affects every risk factor that you have. So if you can keep exercising like that, lowering blood pressure, reducing stress, there's no better pop-off valve than exercise for that. For people that are anxious and going out and doing that. And interval training is probably one of the better ones to do too.
So talk to us, what is interval training?
Interval training is where you're actually pushing yourself to the max, 1 or 2 minutes within a certain aerobic entity, whether you're biking on an elliptical. The great thing about it is you can do it anywhere.
Okay.
So you're able to go ahead and push that and then back off at like a minute or 2 minutes, and then just kind of let your body kind of go back to the
And I read
baseline.
a number of journals that pointed out that sort of exercise seems to lead to lower cardiovascular events as well.
It's one of the few things that increases VO2 max. And so VO2 max is oxygen utilization, and people with HIIT exercise patterns increase that substantially. And I tell people try not to be stagnant with it too. In cardiac rehab, what we do is every week there's 10% increase in something, and like time, distance, or speed. give me one. I don't care what it is. If you're going a mile, go 1.1. If you're going 10 minutes, go 11 minutes. Keep moving the needle to keep improving cardiovascular fitness rather than just saying, well, I did my 30 on the bike today, I'm done, I'm good.
Well, that's a great gem. So that's okay. So that's what you teach your patients at the cardiac rehab program.
Yeah, at cardiac rehab, if you can't progress somebody, they don't get to continue. So I try to use that at home. So
always exercising, you need your headphones.
I need my headphones,
like
apparently,
yeah. There.
Or like it's a little, yeah. I don't have any Beats by Dr. Dre like my son, but anyways.
Okay, and then just moving on from there a little bit. So when you think about exercise, you think about your risk factors. What are the other things that are out there that people are talking about when you? I mean, I have patients that ask me all the time about particular things. So I'll throw out a few topics, and then you can take them. Aspirin. They ask me about, hey, is aspirin still good for my heart disease? Supplements, like people ask me about beet juice and other things. Omega-3 fatty acids and fish oil are the other ones. So let's just take some of them. Let's just start with the overall topic. Are there any supplements that when a patient walks into your office that you would want somebody to take if they're at risk for heart disease? And then let me ask a more pointed question. Do you take any supplements for cardiovascular prevention?
I'll start with no.
Okay.
Okay. Doesn't mean I shouldn't, but maybe no is the first answer for that. But the big supplements that are out there to prevent it, I mean, the first one is red yeast rice that comes to mind, right? Because that's basically the molecule that statins are made out of. That's the base molecule, and all have been derived off of it. So that's available in the stores. People take that, and people that can't tolerate the statin drugs, that's equivalent to about 8 milligrams of fluvastatin, which is one of the lesser ones. If you start 600.
So it's almost like you're taking a statin without taking a statin.
Exactly. So that's helpful. You mentioned fish oil. Fish oil, obviously, I think is that one that helps with triglyceride levels. Some of the earlier stuff with the lower doses of fish oil were more mortality driven after heart attacks, meaning.
So omega-3 fatty acid,
omega-3 fatty acid, fish oil. The other flaxseed oil also.
But going back to omega-3, because I get a lot of questions about it, and I have a lot of patients that are on it. It seems like the data initially, when they looked at populations that ate a lot of fish, they seem to do really well and have lower rates of heart disease. I think we were all excited that, hey, maybe we can just take it, whatever they're doing in pill form, and it works. And it doesn't seem like it works, right? Because in the big studies, it didn't seem to pan out. But now, more recently, Vasipa, which has a certain mix or ratio of the type of fish oil, seems to be beneficial. What's your take on that?
Yeah, and the study on fish oil, Vasipa, is actually pretty good. It's just EPA. It's a dedicated EPA.
So there's two types of
acids, DHA and EPA. And EPA is that cosapenthal acid that's in Vasipa, and that's shown in that population where those triglycerides are up a little bit over.
So it seems to have the
right
proportion of the fish oil molecules that you need.
And it didn't really matter though in that study where you started though. That was the interesting part. Kind of the triglycerides they started with are all the board, but the mortality lowering of about 20% was close to the same in all this population. So is there something else with it? I think that's where people kind of got to go with it. Fish oil itself is, that one is probably the most
promising
and promising for sure.
So we've got red yeast rice, you've got Vasipa, or one type of fish oil, and then you mentioned flaxseed.
Flaxseed is essentially less than an omega.
Okay.
Another one in that class that can help with some triglycerides.
Coenzyme Q10, how about that one?
One study said it worked, one said it didn't, one was neutral.
So do you recommend it for your patients?
I think if people think they like taking it because it helps with the statin drugs and how it depletes CoQ10 for the muscle ache. So I have no problem with people using it. I actually say if you want to try some CoQ10, that's fine.
It theoretically makes a lot of sense at preventing some of the problems that people can have with statins. And I have seen some small studies that seem to be that it shows some benefit, but then I think in big studies it's never really panned out. But like you've mentioned, it probably doesn't cause any harm.
Right.
Yeah.
That's the way
it might help.
Yeah. I approach all the supplements like that. I'm not going to hurt you with doing something like that. And there's very few out there that will actually hurt you. Somebody shows up with garlic. They want to take garlic. Well, garlic has double-blinded, placebo-controlled trials that say it doesn't really do anything to help you. So if you're going to take garlic, is it going to hurt you? So I mean, some people like the peace of mind from reading, from recommendations, from whatever. They just want to do it. And
at some of the stores, they sell these bottles of cardio vitamins and things like that.
Yeah.
Is there any of those that you like that you would recommend? I see the pills here on the screen.
Yeah. HonorHealth had a cardio vitamin that I was looking at, and then most of the supplements within it were actually reasonable, and I couldn't really even list them off on the top of my head right now.
Okay.
But that's one of the ones that I had people kind of going after if they want something comprehensive, and it had plant sterols, which is another supplement that's kind of underutilized. You can't get that through diet, but there's certain foods that are fortified with it that actually works really well. And between red yeast rice and plant sterols and plant stanols, those are probably the two bigger ones for LDL reduction. So.
Excellent. I was going to say, any other supplements that you like of any sort? I think that the reality is that the best supplement is just watch your regular diet when you walk into a grocery store and eat all the right things, right? I think that it's like your own little pharmacy when you're going in there. What you're choosing really can impact what you're doing.
Right.
You like green leafy vegetables that have high antioxidant levels.
Absolutely.
You avoid red meat and cheese and things like that, and high saturated fats.
Yeah, exactly. And if you like, exercise is the best supplement.
But let me talk about a couple of fun ones, because we're all hoping that these things work out for us. And I want to ask you, what's your take on wine? So do you think wine can, that wine can actually prevent heart disease? Is it good for you?
So there's been a lot of stuff about, I'll caveat this to start with, a lot of stuff about alcohol right now. Lately it's come out about cancer incidences and higher mortality.
Meaning that those things can cause cancer.
Yes, cause cancer, so everything. So setting that aside and going to a cardiovascular risk thing, you look at, say, the interest in red wine was from the French paradox, because the French eat more butter, cheese, more high-fat dairy products, more high-fat animal products than the Americans, yet their incidence of heart disease is about a third, 2/3 of what Americans are. And so they think it was because they were drinking red wine every day. So that was the kind of the French paradox. That was the only thing, the dietary difference that they could see. So red wine has flavanols in it, and those flavanols are actually helpful as antioxidants, preventing the oxidation of LDL from getting into the sides of blood vessel walls to start plaques in the heart. It relaxes blood vessel walls to kind of create some, maybe some lower blood pressures too. So there's been some promise and raises HDL levels a little bit too. So there's some data and science behind the interactions of these flavanols with the body that seem to be favorable for cardiovascular disease.
So my take on it recently, and it never makes me popular at a party, is that the red wine data does suggest that there is some antioxidant properties that could be good for heart disease, but unfortunately that there is that increased risk of cancer that probably outweighs any benefit.
Right.
So if you aren't drinking now, if a person doesn't drink, would you advise them to start drinking?
No, I don't think you don't recommend that as a medicine.
And a few years ago we might have said, hey, it raises your HDL, it's antioxidant.
Exactly, and you could have thought about that too, but even like when you go over 1 to 2, which is kind of the recommended or daily allowance or whatever, if you go past that, you lose those benefits of the oxidation and everything else, the good things that the wine can do.
So even when we were recommending it for women, we were recommending one or less glass of
a day.
wine.
Yeah,
and then for men, 1.5 or less usually.
Yeah, exactly.
So, okay, so you're not recommending alcohol anymore.
I'm not recommending it, yes, not entirely, no.
But okay, well, let's hope you're a little bit more fun on this one. How about chocolate?
Oh, chocolate.
Dark chocolate in particular.
So dark chocolate has the same flavanols that are in red wine, just more of them. And cocoa powder has the most potent of those, of any of those antioxidants and the flavanols. So dark chocolate, and the higher the cocoa content, is actually the better for you. Okay.
So that's why dark chocolate, not milk chocolate.
Exactly, and you got to watch for the calories too, because it's still calorie dense. Okay. So you have to substitute that out. But the same sort of thing applies. The same benefits from red wine for the vascular health is the same thing with the cocoa powder.
But not the cancer risk.
But not the cancer risk. No.
So that's
but you can get bigger if you eat a lot of dark chocolate.
Yeah, and so I've read quite a few studies about dark chocolate, hoping that it'd be helpful, and I think the data is favorable. Yeah. But like you're mentioning, that you have to take the trade-off of the calories that go with it.
Sure.
Most of the studies seem to indicate that you had to have to take in at least like 500 milligrams of cocoa, or
3 ounces usually dark chocolate
to get that level of benefit, which would be a lot of calories.
Yes.
If people do want to start on dark chocolate, is there a special type that you like?
Special type that I like?
Yeah,
no,
or is there a percentage of cocoa that you look at?
The cocoa percentage is the most important. The higher the better.
Okay.
That's really what it is. So over 70% or more, and it gets a little bitter, but it's pretty good if you mix it with red wine.
Okay. All right.
So that can be as far as the fun cardiovascular things. Yeah, that can be one of them. Okay. Just got to watch the calories.
Absolutely. And so, speaking of things to take or not take, aspirin. So, for so long, we've had so many people that have been on aspirin, and it seems like there's always news about aspirin. Do you take it? Do you not take it? And it seems confusing. So I wanted your take on it first, then I can give you my perspective as well. What do you think? Should people be taking aspirin?
Yes. I think, if you have a high risk of atherosclerotic vascular disease and you have a low risk of bleeding, then I don't think a baby aspirin is something that should be, shunned and not taken. I think it actually can be helpful from an anti-inflammatory standpoint as well.
What is, just remind everyone, what does aspirin do exactly for the
aspirin
body?
prevents platelets from sticking, basically.
Okay.
So when a plaque ruptures in your artery to your heart to start to begin a blockage of a heart attack, aspirin will prevent platelets from getting in there and sticking to that to create a bigger blockage than you would normally see. So it may not prevent it from closing, but it may buy you even time to get to where you need to prevent that from blocking fully. So aspirin can be a preventive in that arena, I think.
But what are the downsides to it then?
Well, the downsides are bleeding, right? Any blood thinner, we tell people the risk is bleeding, simply. So people worry about gastrointestinal bleeding, especially in the stomach, because aspirin's an irritant. That's why I'm really leery about 325 milligrams in aspirin, and quite honestly, I never use it unless I'm absolutely forced to.
Yeah, so I think my practice has changed as well because of that. So now I usually only recommend a baby aspirin, and only to those patients that have had heart surgery, heart attack, heart stent, and they've sort of proven that they have heart disease. I think in those situations, the benefits of aspirin at preventing a repeat problem outweigh any potential risk of gastrointestinal bleeding or stomach bleeding or irritation or things like that.
Absolutely. Absolutely.
And then you can see this circle or heart here, and just thinking about men and women here for a moment, are there different things that you focus on for women versus men as we talk about sort of February Heart Month and prevention?
When I see them in the office, I think, the risk factors, I don't think change much. I don't think the numbers change for women. I think the way women present with heart disease is different. I think, they don't read their textbook all the times. The stories are different. And so you just got to pay more careful attention to the
signs can be much more subtle of heart disease.
Exactly. The signs are way different. But the risk factors are treated aggressively just the same if somebody has disease. And they also got to go back, like I was saying, like preeclampsia, early menopause, those sorts of things kind of play into that, knowing who's at higher risk too when you see females in the office. But yeah, I think risk factor reduction, for both is important and kind of well defined. I don't think there's things that I do differently drug-wise. Do you?
No, I think the main thing is in medicine in general, I think we've underestimated how women can be impacted by heart disease, and it's so important to recognize that heart disease is the #1 killer for women overall, more than breast cancer and other things. So it's just very important for us to be cognizant of that and aware of it. And as you're saying, so you're looking for subtle signs of heart disease. Exertional fatigue could be a sign of heart disease. Exertional shortness of breath. They don't oftentimes have the classic Hollywood sort of clutching chest pain because maybe they're tougher than us in general. So women can be. So I think we underestimate the risk for women, so I try to be a little bit more leery and just make sure that I'm not missing anything and making sure that we're really vigilant for any symptoms that could lead to heart disease.
You got to. I think you got to rule out.
Or be representative of heart disease.
Yeah, you rule out what's dangerous and then you have time, right? That's kind of what I tell, if we're like, it's really subtle, I'm like, look, let's prove it. Even if they're younger, you can still get a calcium score on them too, and if it's 0, better negative predictive value over 5 years than any stress test that I can give you, right? And you just got to have them buy into that too, So sometimes that talk is, ongoing after that. But yeah, you can.
So, and we're going to get, I think there's a bunch of questions that have come in, but I want to ask you one as well. One of the questions when you do these preventive measures, does the plaque regress? Meaning, like, if I already have a blockage in my carotid arteries or heart blockage arteries, and I have a narrowing, and if I eat healthier and if I exercise, does the plaque go away?
No.
No? Okay.
No. I mean, the simple answer is no. It can be shrunk a little bit. I think Crestor showed a tiny reduction in plaque size. I was talking about the exercise thing, tiny reduction, but you're never going to get rid of that plaque. You've kind of bought it.
That's what unfortunately I tell my patients, there's no liquid Drano system
there is not yet. And I use Drano as well. Yeah, it's good.
And, but I do think that the main thing is to keep whatever plaque is there stable so that it doesn't get worse and that it doesn't acutely get so bad that it causes 100% blockage.
And that's the thing with statins too. People, they will actually increase your calcium scores, because the plaque stability is the other thing of statins. It's not just a drug for LDL cholesterol. It leaches out that lipid core and creates almost like a helmet over plaque that it makes it harder for that to rupture and cause you issues. So that process actually raises calcium scores. So you can put people on Crestor and look at them again in 5 years, and that process may have increased their calcium, even though maybe they may be a little bit safer than you think.
So tonight we've already touched upon knowing your risk factors, knowing your cholesterol, your blood pressure, your diabetes risk, and then making sure you don't smoke, and understanding whether you're at risk because of your family history. We spoke about some of the other things that people underestimate: lack of sleep, stress, poor dentition. We spoke about the ability to focus on your diet as a way to really reduce your risk for having heart disease, and the Mediterranean diet. We spoke about the exercise regimen that you think is best, the interval training and the aerobic exercise, and any exercise that you think you can keep to, any exercise regimen you can keep to. And you gave me your thoughts about chocolate, wine, and aspirin. Are there any other pearls that you have for everyone that you think, hey, listen, this is something you really need to focus on to prevent heart disease?
Those focusing on those risk factors really, I think, covered. There isn't any pearls like within the one things. I think, I tell people with the weight issues, conscious eating, is basically all the stuff that's lying around the holidays, the stuff you grab, and all that stuff counts. A cookie, the chocolate chip cookies is great. That's 250 calories, and I'd say, well, you grab that on the way out the door, and that was nice. But that's an hour, that's 2.5 miles on a treadmill. Okay. And those are the numbers. You got to think about the numbers. And I think the biggest thing is caloric reduction is underestimated amongst all these fad diets and everything else. If you don't have calorie deficit, you will not lose weight. Okay. That's just simple. Physics is real. Conservation of matter is real. And so even all these diets, the ketogenic ones that are not really sustainable, 2 to 6 months, people get that back. You have to have something that is sustainable over time. But you got to be able to kind of do the math in your head. I'm working out, but am I going to kill it with this? Am I going to kill it with that? Never finish a meal. So then I tell people, you can't send it away to starving kids. You're right there. It'd be nice if you could, but you can't. But those little things add up. Doing the little things every day to reduce your calories, 500 to 750 calories a day, is where you end up getting people to lose weight, and that's being able to stick to it, what exercise program they can do every day. So.
Okay, well, there's a few questions here that came in. So let me start with one that came in from Lindsay from Scottsdale. The first question that came in was, what about caffeine? So is there any benefit to your heart by drinking tea and coffee, or is there any harm in it?
Green tea has been shown to have some antioxidant properties that I think that benefit in weight loss. Caffeine itself plays havoc in a lot of symptoms we see in the office. People come with palpitations, they come with high blood pressure, they claim they drank 2 cups of coffee, my pressure's 150. So overall, does it make us feel better in the morning? Yes. Absolutely. Okay. Is there a great cardiac benefit to that? Not that I can see, and it can definitely make arrhythmias, I think, worse. People with palpitations can be worse, so you got to be careful with that.
Okay. So. And the second part of her question was salt. Does it matter?
Yes.
Okay. How so?
Salt matters. Water follows salt in the intervascular space, and so that intervascular volume can be good or bad depending on what you're trying to do. Salt, I think, is encouraged for people with vasovagal syncope, people that get sweaty, nauseated, and fall down. They're usually intervascularly dry. Salt can help them. But if you have high blood pressure and you're having a lot of salt, or you have heart failure and you have a lot of salt, that's going to be detrimental. Your blood pressure is going to go up. You're going to accumulate fluid. You're going to get in a lot of trouble if you don't watch sodium content. And you have to read labels. It's not enough I didn't add salt. You look at a package of chicken that's processed and packaged in there, it's already got your 2 grams of sodium in there. So stuff
I
like
think
that.
I've seen some dramatic impacts to blood pressure by avoiding salt.
Yeah.
I think people oftentimes can even avoid medications if they can just cut down their salt intake and avoid the medications that they might have to take otherwise for high blood pressure. And the things that I notice are that people don't oftentimes recognize that condiments like ketchup, mustard, mayonnaise, soy sauce, those have a ton of sodium in them. So just try to avoid those things. And any canned vegetables usually have quite a bit of sodium. So those are the things to really focus on when we're there. But so great questions about caffeine and salt. Thanks for your perspective on that.
Sure.
The other question that came in was from somebody about what is the difference between heart disease and heart valve disease?
Heart disease and heart valve disease. So I guess the simple way to start is all heart valve disease is essentially heart disease because it's all together.
So valves, you want to just tell everyone
valves,
what are the valves?
4 valves in the heart. There's your aortic valve, all the blood comes out through your whole body. The mitral valve is between the left atrium and the left ventricle. The tricuspid valve is between the right atrium and the right ventricle. And the pulmonic valve goes out and heads to the lungs. And so when those 4 valves can get tight, sometimes calcium can build up on them and they don't open as well. And so that causes problems with blood flow, or they can become perfect so they imperfect so they leak and where they don't come together perfectly. And those leaks or that tightness of the valves, depending on which valve and how bad it is, can cause people problems as it progresses over time. And so you have to know if you have that. I mean, if you're listening to people and you hear murmurs, echoes are great places to start. Then you know how often you need to follow these valves, you know. And the valve disease, unfortunately, really is surgical disease. There's no drugs that really prevent valvular heart disease. You know, statins have been looked at for especially aortic valves, but I don't think it hasn't really panned out.
So, I mean, great question. So I think what you're saying is that valve disease is a type of heart disease.
Correct.
And that unfortunately sometimes the valves are doors that allow for this blood to go from one chamber of the heart to the other or to go to the rest of the body. Sometimes these valves or doors don't open and close as well as they should.
Correct.
And can cause trouble. So great question. Was there another question as well? Yeah, please.
So the first question that came in, let's see, from Charles. He's asking for us to speak about what a good ratio for HDL to LDL is.
So great. Charles has a question as to what is a good ratio for an HDL to LDL. What do you look at for that?
I'm not inclined to do the ratios as much as others. I think the HDL being good over 65 is good.
For healthy cholesterol being over 65,
HDL.
you look at HDL.
HDL.
Okay.
And so that's why I think it's protective. Okay. And so I look at that as being protective, and I don't get really caught up in the ratios of this and that because a lot of times high LDLs track with higher HDLs too. So if you think, well, I'm totally protected, well, those are the people you get a calcium score on.
Okay.
And then you figure out kind of what to do with them.
So if somebody has a high HDL, but they have also a high LDL, so high healthy cholesterol and a high lousy cholesterol, you're still worried about their high lousy cholesterol.
Yeah, absolutely.
Okay.
Yeah, it should be.
Great question. It does bring up another point that's really important is if somebody has a low HDL or low good cholesterol, are there any medications that are out there for that to raise it?
No, not necessarily. Now, niacin, which we used before statins, right, was the only one that moved everything kind of in the right direction. So niacin can raise HDL levels a little bit, but exercise will raise it. Alcohol will actually raise it, but once again, we don't prescribe alcohol to raise HDL levels. And the last drug that they tried to bring to market got to phase 3, but didn't change events, even though even though it did raise HDL. So
I think, but I think that you bring up a good point. Exercise and weight loss can really raise your HDL or good cholesterol.
Yeah,
are there any foods or good fats that can raise your good cholesterol that you like to highlight in particular? Avocado?
Yeah, avocado could be one that you could use. Nuts lower LDL.
Yeah,
for sure, even in larger amounts. You know, I think physicians too, like 60% of us have walnuts or almonds in our desk drawers as snacks, right?
It's definitely a superfood,
Yeah, so yeah, it's good. It's good fats and, it's filling, so. Great question.
So
another question.
Next question is from Mary. She's asking, we touched on, what a calcium score was and kind of what it consists of. She's wanting to know if we would recommend getting a coronary calcium score versus a true stress test, and why, or what's the difference?
Great question. So the question is would you recommend having a coronary calcium score or a stress test? And what is the difference between a cardiac stress test and a coronary calcium score?
Okay. Those are great questions, and they're completely different tests. I think you look at the coronary calcium score as an anatomical test. as far as looking at plaque and seeing if it's there, and it doesn't mean that something's blocked because it's there. That kind of pretends your risk of something. A stress test is a functional test. That's how blocked something is. And that's when you get somebody on a treadmill every 3 minutes, steeper, faster to a certain target heart rate. And then you look for changes in the EKG that suggest blockages. Okay? And so the difference is kind of, they're really looking at completely different things, honestly.
Yeah,
but if your calcium score is 0, though, the negative predictive value of that, still over 5 years, is better than any stress test that I can give you. So it's a very important, I think it's an important test.
Great point. I like to think of it also as that the stress test, which is where we get somebody to run on a treadmill, and then oftentimes we take pictures of the heart when their heart rate is faster, really gives us a sense if somebody has a severe heart blockage at that time that is greater than 70% or more in their arteries, such that it causes heart dysfunction and is indicative of a serious heart blockage at that time. So the stress test can tell us that, but the coronary calcium score can tell us if there's any plaque at all that started to develop, not necessarily whether it's a 70% blockage or not. And so so oftentimes those two tests can be complementary to each other, not necessarily one or the other, but you can use them in sync together. So
very much
great question by Mary. Was there, Lindsay, a few more?
Yeah, there is a few more. So we talked a lot about supplements and different medications, and within the last 2 years, there's been a lot of discussion about vitamin D, vitamin E, and things like that. So one of the people in the chat asked about the significance of vitamin E in cardiovascular health. Is there any relation? Is it beneficial? Should they be taking it?
Great question. So another question, Wes, people have a lot of inquiries and questions about supplements, and in particular vitamins. So this question was focused on, there's been a lot of talk about vitamin D as well as vitamin E more recently. Do you recommend it?
Vitamin E, I think in the last studies actually increased cardiovascular mortality in women in supplements. So I don't recommend vitamin E for really anybody as a supplement. And as far as the letters go in the vitamins, I tell people to get a good multivitamin. Usually get most of it from that anyways. But vitamin E is in excess, I don't recommend. And vitamin D levels, you could find out what your vitamin D level is, and if it's low, you can take the supplement. I don't think you need to take a ton extra of vitamin D. We've kind of put the skin cancer thing in people's heads so well that nobody gets sunlight. They're all covered in sunscreen before they go outside, so you don't get sunshine. And so you don't convert anything to much to vitamin D. So, so levels are low. I get that, and we see a lot of people with low levels, and those should be replaced for sure.
And you brought up checking your vitamin D levels. Going back to cardiac lab tests, are there any blood tests that you do routinely for patients when you're looking at them to try to figure out what is their risk for cardiovascular disease? Do you do any do you do a basic cholesterol test? What are the tests you recommend for a patient?
It depends in the scenario, but I mean, probably the other thing to do is you can look at inflammatory markers for cardiovascular disease, CRP levels. You can look at oxidized LDL levels.
And that's fascinating because what we're learning is that heart disease or heart attacks is not just plaque, but the inflammation in our body.
Correct.
So you're trying to check for that in those blood tests.
Yeah, you can do that. And then you can break down the LDL, particle number, particle size. It's a little bit fancier. We have a lot of different things we have found in the lipid world. We don't have a ton of guns for these targets yet, other than the statin
But
drugs.
So you can check not just I think the point you're bringing out is not just the basic LDL, but oftentimes with your cardiologist, you can check to see whether it looks like the dangerous type of bad cholesterol or something that may not be so dangerous.
Exactly, particle number and particle size. So if you have a high number of particles that are small, dense LDL particles, those are the ones you worry about. So you can break that down.
Okay.
I think one more question. So, and it was perfect timing because you just brought up the diagnostics and things like that. There's been a lot of new diagnostics that have come out to the market in terms of cardiovascular care and kind of more fancy lab tests and things. So someone's asking about the significance or if this is a good test, particularly the cardio IQ test that is offered now. Do you guys know anything about that, and can you elaborate more on if it's a good test or not for them to obtain?
So, Dr. Tyree, there's a bunch of questions a lot of tests that have come out looking at cholesterol, genetic profile, inflammation together. What's your take on these tests? Cardio
That's
IQ
kind
is
of
one.
cardio IQ. That's kind of just what we just talked about, right? It breaks down LDL. It looks at inflammatory markers, and and genetics are part of that. Fine. I don't use cardio IQ, honestly. I haven't used it much, so, but I think that's the way that test is broken down. as far as it's just what we just described, and getting more specific with the LDL, what types of LDLs there, is there inflammatory patterns, CRP levels, things like that. Oxidized LDL, which you have to breach the wall of the artery to start a plaque. So those things are there and important, and you can use those, and that's part of the bigger prevention discussion you should have individually with every patient.
Well,
I think one more question. You want one more question?
Yeah, there's a few more questions. We got time
Just
for
one more, yeah.
Go ahead, please.
This is actually a good one for you, Dr. Shah. So, can the percent narrowing of an artery be measured accurately by a non-surgical procedure?
Yeah, the question is, can the amount of blockage be measured accurately without doing an invasive procedure? And the reality is that when we do stress tests, we are just looking to see if there's enough of a blockage that the heart's in danger. So the heart's not getting enough blood flow. When you're exercising, your heart needs more robust flow through the coronary arteries or pipes. And if there's not that robust flow because of a severe blockage, the stress test is abnormal. So the stress test only gives us a sense of whether or not there's a severe blockage. It does not give us the percentage blockage. So it doesn't tell us whether it's 70%, 80%, or 90%, but it just tells us whether or not there's a severe blockage. There are some newer tests that have come out over the last 5 to 10 years called the CT coronary and a CT coronary FFR, or heart flow, which allows us to more accurately predict whether or not somebody has a severe blockage or not. The imaging on that sometimes is not perfect, so it may not be 100% accurate. The gold standard, unfortunately, to know whether or not you have a severe blockage and what the percentage is an invasive procedure that interventional cardiologists like myself do, where we do a cardiac catheterization. Oftentimes when people are having symptoms and a stress test that's abnormal, where we make a hole in the artery in your wrist or your legs, go into your heart, inject a dye, and then using x-rays we see if there are blockages that are there. And that is the only way you can know for sure what the degree of severe blockage is, severity of the blockage is. So great question overall. Mm-hmm. And I think that what's great is that cardiovascular medicine is advancing quickly, so that we are hopefully able to do more and more things non-invasively and figure out what somebody's risk profile is and danger is. And so I think we're approaching the end of the hour here, but I wanted to say, first of all, thank you to Dr. Tyree for joining us tonight.
Thank you, Maulik.
Thank you for
really appreciate it.
Just all your knowledge and insight. The reality is, unfortunately, this is Heart Month because we need to cast more awareness on cardiovascular disease. 1 in 4 of us will unfortunately die from heart disease, and all of us will know somebody who's impacted by heart disease. And there's also the sad reality that more than half of us have a cardiovascular risk factor that puts us at risk for developing heart disease. So none of us are immune to it. We all need to be vigilant about signs and symptoms of heart disease and do everything that we can to prevent cardiovascular disease. Because as we've heard from Dr. Tyree, with knowing your risk factors, with focusing on exercise and diet, and with doing all the right things, you can prevent your risk for having trouble. And it's really inspiring. So thank you to everyone for joining us tonight. Please reach out to us if you have any questions, and have a good night.